دكتور سامح جاهز؟ بسم الله الرحمن الرحيم. هنبدأ السيشن دي مع شركة سانوفي. الدكتور سامح النعماني هيتكلم على ثرومبو بروفلاكسس رول ان بارياتريك سيرجري. اتفضل دكتور سامح.
مساء الخير. هو طبعا بس انا اسف للانتربشن بتاع جلسات الجراحه العامه القيمه، واعتقد ان الموضوع هيبقى طف، هحاول ان احنا نخففه شويه.
والموضوع عن البيرن ولا عن الثرومبو بروفلاكسس؟ مكتوب ما عندي ثرومبو بروفلاكسس.
هو بيرن انديوزد كواجيلوباثي.
لا، اللي معايا مكتوب ثرومبو بروفلاكسس رول ان بارياتريك سيرجري، عشان كده انا قلت
اللي حضرتك تؤمر بيه.
لا يا باشا اتفضل.
انا سامح النعماني، استاذ جراحه تجميل في كليه طب قصر العيني، وهو الموضوع عن البيرن انديوزد كواجيلوباثي. واعتقد ان كل الناس بتسال هو ايه الجديد، يعني ما هو هايبر كواجيلابل ستيت، بس الواقع ان ده نيو ايتم في الميديسن اسمه بيرن انديوزد كواجيلوباثي، بل نيو تشابتر، لان هو له سبيشال كونسيدريشنز not like any other coagulopathy that we meet. انا اتشرف بانتمائي ل prestigious school في قصر العيني. In the UK, the most current analysis of national database coming from trauma centers indicate that burn contribute to up to 1 in 20 severe trauma admitted in such centers, with annual workload actually increasing. والواقع ان احتياجنا من البيرن injuries نقول ان 10 to 30% of the case should be admitted to the ICU, and hence they need special care. So I think it's a good number of cases that needs to be dealt with like severe cases. Who met this condition before, that we have a patient in the ward collecting his stuff and clothes, intending to leave after discharge, then the nurse is coming to you, doctor, the patient is arrested. I think it is not uncommon to feel this situation, which is sudden death. Sudden death after the patient is mobilized and is ready to move. It's a very bad problem, and it's a very bad scenario endings. Another problem that we met is that we have an electric burn patient, then coming to you in this photo to the left, a small wound in his hand, and the doctor, which is not qualified, asked the patient, okay, go home, and alhamdulillah get salima. Then the patient come to you after day or couple of days with this appearance, this severely mummified hand and severely gangrenous hand. I think this is also a very bad scenario after the condition of electric burn. So it is really a problem of hypercoagulability in burn patient, and the problem is hypercoagulable state. One of the complications related to severe trauma caused by burn is the hypercoagulable state. Although most typically the hypercoagulable condition presents itself during recovery phase, it is not unusual to encounter this in much early stages. The thrombotic complications are responsible for more than 3% death of all deaths in burn population. So it is a major cause of death. We have to consider it. Again, in most of publications, when I was studying my MD, it was called DVT, but now we are considering it, change it to VTE. Do you think why this change in the term from DVT to VTE? No single publication nowadays is writing DVT. It is VTE. Because DVT, it's not DVT thrombosis. I see the picture of venous thromboembolic manifestations, up to pulmonary manifestations, up to death. But so it is correct to call it VTE rather than DVT. Burn sufferers have an increased risk of VTE due to immobilization, trauma, major surgery, including vascular access devices. They are all causes that increase the susceptibility to VTE. So if we apply these indications to Caprini score, which is the classic scoring for VTE susceptibility, I think the patient will have at least 5 points of Caprini score, so he is indicated for chemoprophylaxis. Why coagulopathy? Tissue hypoperfusion, hypothermia, endothelial damage, systemic inflammatory response syndrome, burn wound excision, all these causes leading to coagulopathy. But is it really coagulopathy? In the start, they described it as coagulopathy, but they found most of patients coming from bleeding elsewhere, so they called it DIC. Is it really coagulopathy? Is it really hypercoagulable state? Is it really DIC? I think it is a totally different condition that combines hypercoagulable state and DIC. That's why we call it acute or early onset burn-induced coagulopathy. It is a separate entity of hypercoagulable state or a separate entity of DIC. Shouldn't be dealt with like hypercoagulable state nor DIC. It is coagulopathy. Something wrong in the coagulation cascade. The absence of clear definition or diagnostic criteria for coagulopathy and lack of simple and easy to interpret diagnostic tests could blur the incidence of coagulopathy in patients with severe burn. So we have to standardize the definition. Many trials to standardize the definition of burn-induced coagulopathy. What is coagulopathy? What happened to coagulopathy? Is it clinical? Is it laboratory? I think the most common term is to call it clinical laboratory, but the most important to call it laboratory definition due to disturbance in factor 10, which is the clear definition that proposed to burn-induced coagulopathy. It is not hypercoagulable state, it's not DIC, again, it is coagulopathy. So how to avoid? I think, why it happened? Look to this miserable boy to the left. How to run the circulation? How to run the circulation to the right? Simply by introducing negative suction cranially using the heart and lung machine, then using the peripheral heart peripherally to push the blood. So we have to accentuate this natural mechanism that God provided to us. So the most important is to supply the burn patient with fluids. I think this is the single most important thing to avoid the burn-induced coagulopathy. And when to introduce fluid, it's not like any fluids. We have to find access, which is very difficult to the burn patient. We have to qualify and to quantify the amount needed for resuscitating the patient. And again, the amount needed to satisfy the patient should be closely monitored over the 48 hours, so as the patient may need over or under this amount. Monitoring should be laboratory, bedside, or clinical. VTE guidelines recommend low molecular weight heparin use in all critically ill patients, where there are no contraindications and suitable adjustment to be made for renal dysfunction if required. However, when I say it is not hypercoagulable state, it's not DIC, it is burn-induced coagulopathy. So when you're introducing chemoprophylaxis, it should be in a different dosage, not like any hypercoagulable state. Why? I think during the stages of burn, in the early stage, we have loss in capillary wall integrity in burn sufferers, that all the fluids come out. So we need to increase the dosage in this early stage. After then, increase the cardiac output will increase the doses. So we have to decrease the dosage. What to do? Finally, we have tissue edema that may alter the dose absorption through the tissues. So we have to consider the pharmacodynamics of the anticoagulation rather than usage it. It is not common to use it in the same dosage, either chemoprophylaxis or therapeutic like any other hypercoagulable state. It is totally different. So it is the solo anti-factor 10, which is used for monitoring. We have to closely monitor the patient by anti-factor 10 so as to adjust the dosage of chemoprophylaxis. I think this is another difference that make it special entity with which is burn-induced coagulopathy rather than hypercoagulable state, that the dosage doesn't follow any other conditions in the hypercoagulable states described before. So what are the indications to use chemoprophylaxis in burn patient? I think they are systemic, whether prophylactic or therapeutic, and local, which is a little bit queerly, and we have to consider it in our usage. In systemic, as we told before, we are using in critically ill patient admitted to the ICU. Another indication is the electric burn and anticoagulation. I think the electric burn sufferers should be admitted to the hospital, especially high voltage burn, and should be admitted to full dosage of chemoprophylaxis, of anticoagulation, so as not to avoid this miserable complication. I think another surgical procedure should be done as prophylactic fasciotomy or escharotomy. Fasciotomy should be considered electric burn rather than escharotomy because of the burn is affecting the tissues from inside, outside, not like other burn which affect the tissue from outside to inside. Electric shock as well should be considered for chemoprophylaxis. So what's off-label use of anticoagulation in burn injury? What do I need by off-label usage of anticoagulation? When the FDA approved anticoagulation for treatment of critically ill patients, they approved it for chemoprophylaxis, for burn, for hypercoagulable state, but they doesn't approve it for local usage, which is called off-label use. The FDA approved the product, but didn't approve the usage, what we call it off-label use of anticoagulation. In fact, we have 3 zones of burn histologically that we call the Jackson burn model. The zone of necrosis, which is central, then surrounded by zone of stasis, then surrounded by zone of hyperemia. What makes burn progressive? What makes the burn sufferer come to you in the first day, which has first or second degree burn, then you're surprised that the third day, fourth day, he came to you by deep burn. What happened? What happened that is the zone of stasis extend on the condition of zone of hyperemia. What happened then? The zone of hyperemia underwent more coagulation for the minor vessels. That increases the zone of stasis. Again, zone of necrosis start to invade the zone of stasis. So how to minimize this spread? I think this is the off-label use of anticoagulation, which was first described in 2015 in Ghana by publication in Ghana. They used it locally to improve the vascularity. Then in India, they used it in 2017 to improve the vascularity. Then by the Egyptian group in 2020 to increase the vascularity. I think no clear evidence based to that it increases the area of clearance or clearing the area of stasis or decreasing the possibility of area of necrosis. No clear evidence based. The results that they reached in all their publications that it relieves pain, it improves healing. But I think we are lacking objective histological study to prove that the zone of stasis will decrease. I think we are lacking this, and I think we need more animal studies to prove this condition. But look, this publication in 2023, there is a trial to use local anticoagulation or oral anticoagulation to improve wound healing. Will it occur? Anyone tried this before? I think we all heard about hyperbaric oxygen. We heard about it. Hyperbaric oxygen is the patient has a problem in wound healing, either burn or any other causes, that he stand in a closed cabinet with hyperbaric oxygen. It is clearly evidence-based that it increases the blood flow to the area and increases the oxygen carrying capacity to the hemoglobin in this area, thus improving the healing. Why don't we deal with anticoagulation like the same way? Why don't we improve the vascularity by make it more liquid together with hyperbaric oxygen? I think it will improve greatly the healing in any chronic wound or even in acute burn. It will reduce the extent of zone of necrosis. So this is not a publication. This is an article in a journal, but it is a purely scientific article called "The Impact of Oral Anticoagulants on Wound Healing and Development in an Aging Population," like anti-aging, like anti-wound management. Thank you, and I'm waiting for your questions.
دكتور سامح، طبعا انت عارف احنا جراحين عموميين، ما احناش جراحين تجميل. انا الحقيقه اتلخبطت. انا عايز اعرف دلوقتي لما يجي لي عيان عنده بام، هديله انتي كواجلنت ولا مش هديله انتي كواجلنت؟ امتى اديله امتى ما اديلوش؟
طيب يعني هنتكلم، انا طبعا اتشرف ان انا تعليمي كله جراحه عموميه طبعا. فهنتكلم كلاسيك. هو العيان البيرن ايوه يا اما يقعد في بيتهم يا اما يخش مستشفى. واللي هيخش
في بيتهم ده ماينور،
واللي هيخش مستشفى
ايوه
يا اما يقعد في الورد يا اما هيخش اي سي يو.
كويس.
انا بقى همسك العيان اللي هيخش اي سي يو which is major burn.
اوكي.
systemic inflammatory response syndrome ليه 3 اسباب: major trauma, major sepsis and major burn. So it is hypercoagulable needing anticoagulation. بس should we consider it زي major trauma أو major sepsis? That's why I'm transferring my knowledge that it is a separate entity. عشان كده it is called burn induced coagulopathy. It needs anticoagulation but in a separate dosage and should be monitored in different way.
In a separate dosage and
should be monitored in different way for anticoagulation.
ازاي؟
انتي فاكتور 10. لان زي ما انا قلت العيان في اول فتره بيبقى عنده مشكله في الكابيلاري بيرميابيليتي، فكل الدواء اللي انت بتاخده بيخرج في الانترستيشن، فالعيان ما بيستفيدش بيه، فمحتاج ان انا ازود الدوز. بعد كده العيان بيخش في الهايبر دايناميك ستيج، فالكارديك اوتبوت بيزيد، فالدواء اللي انت بتديه بيخش جدا السيركيليشن، فمحتاج ان انا اقلل. بعد كده العيان بيخش في حاله الاديمه، انا ما اعرفش بقى الاديمه دي الدواء خرج دخل، فعشان كده انا محتاج ان انا امونيتور الدواء ده انترافاسكولار عشان اعرف العيان ده should be adequately monitored.
اذا عيان الباب اللي هيدخل انتنسيف كير محتاج مننا نعمل له
انتي فاكتور 10 close monitoring for calculating the dosage.
To calculate the dose of anticoagulant. صح؟
ده حقيقي.
كده مفهوم. العيان اللي في الورد لا.
العيان اللي في الورد لو هو داخل لمجرد انه الكتريك بيرن ده مش محتاج ان هو يخش اي سي يو. هيخش في الورد، بس العيان ده على طول هدخل اعمله فاشيوتومي وامشيه على ثيرابيوتيك دوز اوف انتي كواجيليشن.
ثيرابيوتيك دوز اوف
انتي كواجيليشن.
انتي كواجيليشن. اوكي اتفضل.
شكرا يا بيه قوي على المحاضره القيمه دي. هو حضرتك وضحت بالنسبه لل الهاي، في عندنا حاجات بتعمل هاي ريسك ومحتاجه انتي كواجوليشن، يعني هل ده اولد ايج، هل دي واحده ست اوبيز، يعني الاوبيزيتي الريسك فاكتورز اللي بتزود الكواجوليتي. فهل الميجور بيرن ده هيتحول لو هو مودريت مش ماينور، يعني اقل من الميجور بيرن شويه حوالي 30%، هل ممكن الريسك فاكتور دي تحولنا ان احنا نبدا معاه انتي كواجوليشن؟
ميجور بيرن اتسيلف نقل العيان ل 5 بوينتس كابريس.
مش ميجور. هو مش ميجور، يعني مودريت بيرن مع الريسك فاكتورز.
ساعتها هنزود احتمال الاموبيلايزيشن والهايبوفوليميا، فدول another 2 points should be added to Caprini score.
دكتور سامح بيه كتر خيرك على الكلام الجميل. بالنسبه للبريجننت لهم بريكوشنز خاصه شويه
بالنسبه لايه يا فندم؟
البريجننسي، مع البريجننسي بيبقى في بريكوشنز ادق شويه معاها لو ميجور بير.
هو انا مش تخصص نسب، بس اعتقد ان هو هيمبروف البريجننسي، يعني اعتقد في عيانين كتير حوامل ماشيين على انتي كواجيليشن، فاعتقد ان هو ممكن يزود الدنيا، الا لو هي عندها اوريدي مشاكل بقى في البلاسينتا والحاجات دي، فدي بقى يعني
ده موضوع تاني.
انا طول عمري بعيد عن النساء.
الحقيقه اشكرك يا دكتور سامح، الاستاذ دكتور سامح النعماني، استاذ جراحه التجميل في القصر العيني. شكرا جزيلا على
شكرا.
المحاضره، وان شاء الله نشوف